Hello, everyone. Good morning to all.
Hello, good
Hope you
morning to
guys.
everyone. Welcome, Dr. Bruno. Thank you. Thank you for this webinar. I hope it's going to be very exciting as the topic is extremely exciting and sticks with everyone uh, for everyday practice. We have lots of people joining. Wow. I also have some of my team members joining for your webinar.
Great. Most of people are from India and Emirates.
Yes. Emirates, India, Poland, Lithuania. I think it's also from Europe. Yes, I think some parts of Europe, Africa, both West and East, and Central.
All places with better weather than here in Ireland. We were on a dry spell for 2 weeks. It was really nice. The weather was lovely, but now we came back to the proper standard weather with clouds all over. Christ. Yeah.
I think
So can we start?
we already have 22 people. Yes, we can start, and I can keep on adding them throughout the webinar. So
Perfect.
welcome everyone. Thank you for joining. We have an exciting day today. Uh, I would like to introduce Dr. Bruno Rees. He is our KOL from Root, Ireland, and he was also an associate professor of Royal College of Surgeons, Ireland. One of the best clinicians. He has tremendous amount of knowledge in all aspects of implants, and I'll leave it to you, Dr. Bruno, please.
Great. Thank you for the opportunity, for the time of you all. I don't know if the time zone is the same. Here is 10 in the morning, so early in the breakfast. For some of you, it's lunchtime. But still, it's always good to see that people still have this interest to keep learning, and grow in the profession as a dentist itself. So I will try as well to answer along the presentation any questions that you have. Just send it here, or if not possible, by the end of it. Okay. I would like to say that I will leave my Instagram at the end. I have there a link for just a checklist of everything that you would need to check with the patient, throughout the consultation, so you can know necessarily at what risk zone that patient would be classified. Okay. So to start with, the key point of this lecture would be to move away from asking only, was the implant placed correctly, and instead ask what combination of factors could transform a stable implant today into a failing implant tomorrow, and that, to understand that, we change it for everybody. Good. Okay. So to understand that, we need to realize that implant failure should not be understood as a single and isolated surgical complication. It's just not that. In most cases, failures is the final expression of a sequence of a biological, mechanical, prosthetic, and maintenance related event. Maintenance for this is really important as well. So an implant may placement may also integrate initially and may function well for a period of time. Okay. However, this apparently stability does not guarantee a long lifespan, and a long success for the implant itself. And for that, we have a long list of aspects like systemic conditions, bone quality, surgical trauma caused at the moment of the surgery necessarily, insertion torque. I was discussing with Dr. Salman as well just right now, micromotion, prosthetic design, soft tissue profile, occlusal overload afterward, and plaque control, as well as maintenance habits for the all influencing the biological environment or around the implant itself. Okay, sorry about that. It's just the screen. So, in summary, by understand implant failure as a process necessarily, we can identify risks earlier and modify our treatment planning, choose safer loading protocols mainly, okay, and adapt everything to the patient peculiarities, okay, improving like that the prosthetic design and creating some maintenance strategies that would protect long-term outcomes for the patient and for us necessarily as well. Nobody wants having problems on the long road. So we can then organize implant failure into 5 major areas that must be assessed together. For that, I've used an article from El Aksari from 99. Okay, he organized the failure in actually 7 in 7 items, but I just restructured the article so we can better understand that as a process necessarily. So just putting together a few things as metabolism and systemic conditions necessarily. Okay, so first of all, we will look at failure as a process. So this means that understanding the timeline for primary stability to long-term maintenance would be key for that, okay? In second, we will be discussing host and metabolic risk. Okay, so the patient's systemic condition, it can influence healing capacity, immune response, and bone metabolism necessarily. Third, we will review medication-related risk, some medication and some orders that we are not as trending as some, but they are quite important as well. They can literally be neglected and be influencing the results that you have. So some medication can interfere not only with bone remodeling, but also soft tissue healing. So medication history is something necessarily that it has to be interpreted and not only recorded on the file. Okay. Fourth of all, we will focus on the local site, bone volume, quality, thickness of the buccal plate, phenotype of the soft tissue, graft stability, how long that graft has been placed there, and the type of graft. Okay, very often implant failure is not explained by the general health of the patient alone, but by the local biology and the position of the implant around the envelope necessarily. And finally, the final aspect will be connecting torque, loading, prosthetics, and maintenance to all of this information. Okay, this is important because risk of failure does not end when the implant is inserted. It's actually starting just from there. Excessive torque, poor emergence profile, residual cement, occlusal overload, all of that can interfere with the long life of the implant. So going back to the first key message, failure is a process, okay? This is extremely important because clinically, we often look at failure only when we have mobility. Okay, so if the implant is shaking, okay, we have some problems there, suppurations present, or when radiographic bone loss start becoming obvious, okay? But by that point, the biology or mechanical problem, they may have already been developing for quite some time, okay? So instead of thinking of failure as one moment, we should think of it as a sequence. The timing of failure help us understanding the dominant mechanism that happened there. Early failures are usually more connected to healing and osseointegration, okay? And late failures are usually more connected to peri-implant inflammation, prosthetic complications, occlusal overload, so problems on necessarily adjusting the bite afterwards, and failure in the maintenance as well. So when we understand the process, we can then become better at prevention as well. So now it is necessary to understand the timeline for implant integration. And to start connecting the dots, we and come with a plausible reason for its failure. We have here the transition from mechanical stability to biological stability, so primarily to second stability. And each stage would suffer more from one aspect rather than the other. Okay, so on day zero, the implant is relying only on the mechanical engagement, and that depends on the implant design. Okay, as we can see here, I don't know, you can see the dots going around. Okay, so the root Viper edition, it comes with several features to improve necessarily the prime stability. So the V shape of the body that differs from the shape of the threads. So the threads can become more aggressive as well and increase the torque. But at the same time, we can see kind of a progressive change on the threads from V shape at the apex to a more squared at the cervical, at the crestal area. So this is quite important because necessarily of the torque. Okay, V shape threads, they create more compression. They create more actually stress on the bone. So when you insert the implant, they are quite useful to increase the stability. But at the crestal area of the bone, that bone is more sensitive to pressure, is more sensitive to tension. Okay, so the squared threads, they distribute better the tension, that distribute better the compression around that area, and it's there necessarily to preserve the crestal bone around the implant. Okay, so we can see here, and that can explain quite much from the early days of implants when we had all the cylindrical implant from Brandemark, and from there, and a fully machined surface. And from there, we learned a lot on what features on the not the only the macro geometry of the implant, but also the micro geometry, like the surface treatment of the implant. It would be necessary to change so we can have something more reliable nowadays, not only to increase the primary stability, the initial torque, but also to improve the transition into the second stability. Okay, so we know better now that the main goal is not necessarily extreme high torque, and that's quite important as well. Okay, it is necessary to gain stability, but without creating excessive compression of the surrounding bone, because primary stability should support healing, and healing is extremely compromised by the lack of vascularization, and the increase of bone remodeling. So as much torque, when you pass over 4 to 5 newtons of torque, you start creating more compressions on the surrounding bone, and mainly depending on, we are going to see later, depending on the type of bone that you're using, that you're drilling through. If it's a more trabecular one, it would be fine. The trabecular one can accept more compression, can deform better under pressure. But if you're dealing with a D1, a D2, with more cortical structure, that cortical is poorly vascularized, is not, it doesn't have the same aspects as the trabecular one, and it will suffer more with the torque. I was saying that on my early days as well, I had at least two cases with the same aspects. I placed the implant good and very well positioned, a really high torque. It was trending. Okay, let's put as much torque as we can. So on one of them, I can say that I reached 60 newtons. And at the end, after 2 months, I believe the implant just came out. And why is that? That much pressure put too much. It was this specifically was for 23, so upper left tree. So it was compressing too much the cortical of the patient, the on the buccal aspect mainly, and that led to absorption of that cortical of that bone wall. Okay, which it's crucial for the preservation of the aesthetics as well, considering that's aesthetic zone. So I managed to fix that. I placed the implant more palatal even, curving more the crown necessarily at the end. It took quite a while for me to fix the problem, kind of gaining the curve of the bone again and all that stuff. But like, thankfully, it was sorted. So that's why the torque needs to be measured for the condition, not like something optimal necessarily, like a number, but for the condition of the bone and the condition of the patient that you have. So it's quite important for you to feel during the surgery what you're dealing with, so you can then insert the implant appropriately. Okay. And after day zero, if the bone is dense, okay, we may have achieved high torque quite easily. But as I said, we can create problems during the insertion. So all of that needs to be measured. Okay, so at this stage, the implant is not integrated biologically. So we are relying only on the mechanical aspect of the implant. That's why an aggressive implant is better for achieving this primary stability, which is important as well for reducing the micromotion of the implant itself. If the implant starts moving over than 150 micrometers, you can have the failure of the implant instead of having bone to implant contact, instead of having bone forming around the implant. You can have some fibrosis, and that is, you can even feel when that happen, let's say some resistance at the time that you take the impression, at the time that you insert the transfer or the scan body. You can even feel that is okay, that's good. But at the time that you place the final torque on top of the implant can snap off. No, that's because of the micro motion necessarily. And after day zero, we start entering to the remodeling deep and micro motion risk during initial healing there. So during the first 3 weeks, the implant is in its most vulnerable biological phase. Okay. In a short time, the compressed bone around the implant starts to remodel. So we have the osteoclasts absorbing all of that compressed bone without vascularization. Okay. And then this can create a temporary reduction in stability. It will necessarily. And before, that's the main thing that will happen before new bone formation is strong enough to compensate for that. Okay, so this is the moment where micromotion becomes critical. If implant is overloaded during this phase, and we are talking about single crowns or bridges, okay, uh, especially in soft bone as well, osseointegration may be disturbed and replaced by fibrous tissue formation. Okay, the same does not apply to full arches. because the connection, the, let's say mainly the AP distribution, can reinforce the stability of the implants. Just like if all holding hands, they can resist better to occlusion, to the movement itself, instead of just a single crown. So for the single crown, you need to be more precise, more delicate regarding and measuring the primary stability that you have, the timing of the temporization necessarily as well, and how you adjust the temporary. Okay, so this is also the moments, the moment where failure will be guided more intensively by metabolic disturbances as well, because of the lack and disturbance on the formation of the bone. So from around week four, that's when we have the lowest stability for the implant. Okay, but from there, the second stability starts kicking and starts to become greater than the primary. Okay, this means that the stability is no longer coming only from mechanical engagement, but from new bone formation and increasing, as I said, bone to implant contact. Okay, however, this is still a healing phase. The implant may feel stable, but the interface is still maturing. The week four is in reality the moment with the lowest nominal stability throughout the process. Okay, so loading decisions, they must be controlled at that moment. We need to consider bone quality, implant position, okay, again, occlusion, power function of the patient, if the patient is a grinder, is a bruxist, if there is other problems with the occlusion necessarily. Sometimes the antagonist is over extruded, so it's gonna be hitting differently with a premature contact on the side movements as well. And whether the implant is single, as I said, or splinted. Okay, so after osseointegration is established, the risk profile changes again. Okay, at this stage, the implant is no longer mainly threatened by early micromotion. It's much more stable, but by long-term biological mechanical fact, the threat here would be long-term biological and mechanical factors. Okay, so more at this stage regarding the maintenance, how the patient, and also systemically speaking, interacts with inflammation around the implant, and the maintenance of the hygiene necessarily. Okay, so maintenance, as I said, becomes critical. Plate control, peri-implant tissue, regular reviews with the dentist. This is quite important and really neglected. We inform all the things for the patient, but the patient thinks that the implant is the final solution for his absence of past hygiene. He didn't brush for 10 years. He lost his teeth because of that sometimes, and now he thinks that placing implants, he doesn't have to brush as well. I have some patients that after 3 months they come with build up with tartar all over the implants all over again. For these patients, it is quite important for you to first change your consent form, so you can adapt this quite clear for the patient necessarily, so you don't have problems, and inform and reduce the time spent between the reviews. Okay, instead of every 6 months, just bring the patient every 3 months. Otherwise, you're gonna have problems with that necessarily. And at the same time, the occlusion, it must be monitored. Okay, because occlusion necessarily changes over time. So while the time passes, the other teeth, they are gonna be reduced, they are gonna be grinded, and that at some moments can become a problem for the implant. There's a I don't rem it was on the Journal of Prosthetic Dentistry. I don't remember. I can come with that later, but showing that with time the interproximal contact of the between the implant and the other teeth, they can change drastically, and that can open a gap that will lead for impactation of food, and that of course for the peri-implant region it's quite bad. And also the patient for an implant is just like a patient with heart problems. For it needs to be reviewed, it needs to be reassessed for the rest of the life. Uh, so it's important to highlight that implant success does not end again after osseointegration. Long-term survival depends on controlling inflammation, controlling forces, and keeping the patient under maintenance, okay, for the long term. However, all this can change when considering immediate implants and the volume of graft used, okay. In immediate implants placement, the transition from primary to secondary stability is not the same as when you're doing an implant on a healed ridge. Basically, we are talking about an implant that will heal with native bone, but as well with grafted bone. Okay, so when part of the implant is not in direct contact with native bone and is instead surrounded by either cloth or bone graft, that area necessarily does not provide true mechanical support at day zero. And more critically, it can interfere considerably with the stability curve, and it may become vulnerable after some time. Okay, so primary stability would depend on less native bone contact then, and secondary stability may take longer to become clinically protected in those graft regions. Okay, considering the volume, because the graft relies also on vascularization. So depending on the apport of blood, on the blood supply that you have, it may take longer for the bone turnover of the graft. And we also are counting on this vascularization and turnover for the second stability in the bone to implant contact. So if we have a larger volume of graft, we can consider that the contact in between the graft and the implant, it's gonna take longer to heal as well. We cannot consider that this is gonna be the first part of the graft to heal, and okay, and all the rest of the graft will heal later, and there will be no problem. So if you're considering an implant with a larger bone graft, considering as well to take impressions to rehabilitate that after a longer time instead of 3 months initially, 4 months, 5 months necessarily. It all depends on on your surgery, so the peculiarity of the surgery that you had. Uh, Most of cases, what happens is that when we place immediate implant, we have the primary stability only on the apical part of the implant, as I said. Okay, so the implant may feel stable initially, but the biological transition is much, much more vulnerable. And the larger the graft is, as I said, or unsupported area around the implant is, the more we should protect the implant from micromotion. So not only considering longer healing period of time, but protecting as well from functional loading. Okay, so instead of perhaps using something like a healer or something that could have any kind of loading at the top, considering just leave the implant totally under the tissue. For some cases, that can lead to more work or more trouble to then dealing with the soft tissue later. But like still, you're gonna have the survival of the implant instead. Like at this stage, that's most important than trying to do everything at what just once, and throughout this just risking the survival of the implant. Now that you understand the stability timeline, we can separate implant failure into early and late failure. Okay. So as I said, earlier failure usually means that the implant did not achieve or maintain osseointegration. Clinically, this may present as mobility before loading, pain during healing, radiolucency suppuration, or fibrous tissue around the implant. And if the implant is mobile, the procedure is usually to remove the implant immediately. Okay, if you have that instability of the implant on an early stage, that's not going to improve. Okay, so remove the implant, deal with the area, if it's grafted or not, just clean the area, leave some time for the bone to heal. That it's gonna take longer. Inform the patient that the timeline for the treatment's gonna increase necessarily, but like at the end you may have better results, and it's gonna be possible to do another implant on that site as well. And any fibrotic tissue as well, or granulation tissue, should be removed, okay, when you remove the implant, because that will not guarantee, but it will improve the chances for bone formation. If you have tissue already, a fibrotic tissue that will hold the formation of bone, that must be removed, so you can then have more chances for the bone to close. And it's always easier when you talk about that when you have a surrounding bone around the area of the implant, and the grafted area is not as much. If we are talking about GBR, that you had to increase the height, then it may be a bigger problem, because that area tends to absorb more and remodel more. So this is also part of the planning. If you have to increase the height, sometimes it's better just to do in stage. Do first the GBR, deal first with the bone grafting, and on a later stage, when you are now sure that the bone is consolidated, then you place the implant in the area. And the decision necessarily to graft immediately as well, or wait, depends on the size of the defect. Okay, if the socket walls are preserved, as I said, there's no acute infection, graft may be considered. Now, if the site is infected, inflamed, or unstable, it may be safer to debride the site, allow the healing, and then return with a staged plan. Okay, yeah, even for the graft, just deal with the infection, do the graft, and then even later an implant. Okay, so late failure now, it's different than the implant initially integrated. But the long-term biological or mechanical environment became unstable now. In late failure, we should not automatically remove the implant. It's a different approach. So first, we diagnose the cause. Okay, if it's a perimplantitis, the problem could be residual cement, a screw loosening, or maintenance failure. All of that can be the main cause. And if there is progressive bone loss, but the implant is still stable, a treatment could be just decontamination, some correction of the prosthetics, occlusal adjustment, and improving the hygiene access for the patient. Of course, this can lead to problems with the aesthetic, but not necessarily. The progression of bone loss, it can be stopped, and the lifespan of that implant can last much longer. If you stop the process, if you intercede in an early stage. Now, if the implant is again mobile or has severe circumferential bone loss, or if by any chance it cannot be maintained prosthetically because of other reasons, then again the removal of the implant becomes the safer option. Okay. Now, starting with uh, the patient history. Okay, to collect the patient's health history is extremely important, not only to legally protect you, but also because implant failure is not only a local surgical event. As I said, the implant heals inside a patient, and that patient may have systemic conditions or behavioral risk factors that would interfere heavily with the treatment proposed. Okay, the most important message here is balance. Okay, a systemic condition does not automatically mean that the patient cannot have implants. Okay, the real question is the condition controlled? How severe is the condition, or how long has it been present? What medication is being used to treat the condition, and how should the treatment protocol be modified for that patient. Okay, so in other words, we should not only record the medical history, but we should again interpret it. Okay, the most common of them, of the systemic conditions that we need to interpret, is diabetes. Okay, we can have, I don't know if there's much changes in the number of diabetic patients here in Ireland. Actually, I don't have much, but I know that it's quite drastic in the United States. All depends on the lifestyle of the patient, how many sugar intake the patient has as well, mainly for type 2. But interpreting it is not only to ask if the patient has diabetes, okay, but to make sure of how well is controlled. Well-controlled patients can have very good implant outcomes as well. So diabetes alone, as I said, is not a full contraindication, okay? The risk increases when the glycemic control is poor, when the patient has long-standing disease, vascular complications, and mainly poor plaque control, okay? Because that interferes quite strong with the patient's disease as well. Now, to clinic assess the patient is not only to check the level of sugar at that moment. Okay, that can be quite misleading. Diabetic patient can be quite severe, and at that day the sugar level could be fine. Okay, so the best would be to order blood test for glycate, for the HbA1c, for the measuring the glucose that actually is attaches to hemoglobin. Okay, because the glucose itself, it attaches a long time with the hemoglobin into the red cells, and the red cells, they have a lifespan of 2 to 3 months. So every 3 months all your red cells should be renewed. And when you ask that exam, the glycate hemoglobin, you can now see, and the one artifact is that the glucose attaches irreversibly to the hemoglobin. Okay, So let's necessarily, when you read that level of hemoglobin that are affected by glucose, you can not only read the moments of the patient, but the history, the past history of the last 3 months of the patient. So how did that patient reacted? How did it stand for the for his condition throughout the 3 months? Okay. So in that case, in practical terms, I would say when the patient shows below 6.5%, that is usually a safe zone, okay, for you to place an implant. But between 6.5 and 8%, we may still proceed, but depending on the case, okay, if the patient necessarily has a really and strong good cleaning, a really good oral hygiene, there's no further complications, it's not a bruxist. So if there is anything, if there isn't anything adding to the problem, you may proceed. Okay, so but above that, or if there is any further problems adding to the patient, the recommendation mainly from the American Diabetes Association is to postpone any elective surgeries, okay, until the medical control improves. Okay, so for a controlled patient, again, I would consider timing and choose delayed protocol necessarily, even if it's for a controlled patient. It's never bad to be safe in those cases. Reduce surgical complexity as much as you can. And instead of doing everything in one stage and trying to be the Superman, I would also consider to a more stage approach. Okay. I would necessarily avoid immediate loading unless conditions are excellent. As I said, control the torque. As higher torque would lead to more bone remodeling, and that patient necessarily it has problems with the bone remodeling. So I would quite control the torque. Uh, and also, even with the glycate hemoglobin, it would be good to check the glucose on that day, okay, as also severe hyperglycemia, it may increase the risk of infection. Okay, so even if the patient has been controlled for 3 months, but now at that day is having something out of control, that may not represent a problem with the integration, but it can give you a problem with an increased infection, okay, on the side post-surgically. Just a second. Okay, and one of the most common systemic, no, that's exactly what I said. Okay, another common health condition you may find is osteoporosis. Okay, especially in post-menopausal women because of the drop of estrogen. So that you when you have as the patient comes to your practice, you just starting reading the patient as that. Uh, but like osteoporosis, it may also affect men and younger patients. So it's always good to again keep asking, not only for the diseases but for the type of medication that the patient is taking. And that is actually something important. And I have an example for that not far from my family. It was with my mother, and she's a dentist, so it can happen to everyone. My mother was with the GP, and he asked my mother if she had high blood pressure, and she said no. And I immediately like, what? I know you have. And but I take the medication, so I don't have the high blood pressure at all. Come on. You're the one suffering from this, in your clinic, and now you do the same as your patients do. So ask not only for the disease, but also check the medication that they are taking, so you can connect the dots there. Uh, and younger patients, again, with hormonal disorders, chronic diseases, and malabsorptions or long-term medication. And that we are going to see a really long list of medication that if you take long-term, you're going to possibly having high risk of osteoporosis. One of them, just jumping to that, is a patient that usually is okay, has asthma from child, and he takes corticoids for controlling it. The corticoid itself can increase the risks, can increase can drop the density of the bones quite much. So if you have a patient like that, keep an eye on that as well, so you can let's say foresee any problems that could be ahead. Okay, so the important point is that systemic bone density does not perfectly predict alveolar bone quality as well. So a patient may have osteoporosis on a DEXA scan, on a scan done for necessarily for knowing the density of the bones, but he can still local jaw bone in good condition, okay, for primary stability. And on the other hand, you can have a patient without osteoporosis or without something diagnosed as osteoporosis, and you still have a very poor, mainly on a posterior maxillary bone, okay, with a really low density. I had a patient once, and she didn't have any complaints regarding osteoporosis, but when I was placing the implant, with just the pilot, I could just, without rotating it, just pushing the pilot into the bone, and that's it. Right after that, I've placed a 4.2 implant because the bone was so soft. I prefer to increase the stability to just kind of compact the bone around with the implant itself. At the end, it was still possible to do a full arch for her. So the best would be to use a CBCT to add some information, okay, about the jaw bone density. So we must separate systemic diagnosis from local implant planning, okay? And locally, we need to evaluate cortical thickness, trabecular pattern inside the bone, ridge, volume, and any possibility of apical anchorage, if you can. In those cases that you see that everything is more trabecular, if you can try to achieve double cortical anchorage for the bone, it would be better. The biggest clinical issue here is often not osteoporosis itself, but the medication used to treat it. Okay, this is why anti-resorptives such as biphosphonates and denosumab, they deserve their own slide. We are gonna check about that later. Okay. Now, an important information, and again, this is quite often neglected, is smoking, okay, and nicotine exposure, as it can affect implant treatment at multiple stages, okay, not only on early healing, but afterwards as well. In the early phase, nicotine itself causes vasoconstriction, okay, so it can reduce the oxygen tension and blood supply to the area that you are placing the implant. Uh, and it is important here not only to ask the patient to stop smoking, like throughout the healing process, or at least reduce it, but like also check the past of the patient. If the patient is a heavy smoker, quite possibly he is already compromised, you know. So quite possibly he has only the main vessels, only the aorta and the blood pumping blood, you know, all the rest is blocked. So and the blood, it's really essential for implant healing and bone repair. Okay, so smoking also modifies the immune response and the collagen metabolism of the patient. This means higher risk of delayed healing, wound recessions. If you are speaking about a patient that you have to do a larger and bigger volume of graft, and for that, protecting the graft, you need to kind of pull more of soft tissue on top of the graft. That patient will have a larger retraction, a larger, let's say, yeah, the adhesions, and possibly exposing the graft necessarily. Infection and early implant complication as well. Okay, in the late phase, smoking increase susceptibility for peri-implant inflammation. You know, not because as we said, it disturbs the immune system of the implant. So the implant, the area will be more susceptible to bacteria, and this is especially relevant when necessarily combined with a poor plate control and history of periodontitis. Okay, if the patient on top of that is diabetic as well, like, it's better not. Just tell the patient to, if possible, to look for a bridge or a denture. You know, your patients, your implants are possibly gonna have trouble. Now, another item as well, and it's quite trending, is the amounts of vitamin D. You know, that's a problem that I have here in Ireland. We don't have sunlight, so all my patients, I have problems with vitamin D necessarily. So it is not, the vitamin D deficiency is not a classic contraindication for implant therapy. Okay, but it is a modifiable metabolic factor necessarily. It is involved in calcium metabolism, bone turnover, again, immune regulation as well, muscle function, and immune response. So in implantology, the evidence is not strong enough still to say that the vitamin D will always cause implant failure. You know, we are gonna have necessarily patients that we would need some vitamin D, and you did the implant, and the implant was fine. However, when we are planning a procedure that depends on bone healing, mainly like graft integration, an area that the graft will be, let's say, the main solidly structure to hold the implant, like a patient that has only 1 millimeter of crescent bone, you have to add more with sinus lift, and your implant is going to be relying only on grafted bone, you know. And I would check necessarily for that patient the level of vitamin D, you know, so you can guarantee, or at least it would make sense, you know, to check whether the patient's bone metabolism is working in our favor. Okay, before doing anything. So the basic test for that is the serum 25 hydroxy vitamin D. Okay, you can check that on internet, anyways, for the name, like what's the how do I check for vitamin D. So the deficiency is often considered below 20 nanograms per milliliter. Okay, and severe deficiency especially below 10 nanograms per milliliter. So if you're facing a patient with 10 nanograms, that is quite severe. I would necessarily, for that patient, stop any plans for the procedure, treat and supplement the vitamin D first, and then think about following, see, check again for the stability, and then proceed with the implant itself. For clinical planning levels above 30 nanograms per milliliter, they are general more acceptable. Okay, in more demanding cases, such immediate implants, grafting, sinus augmentation, the optimal would be aiming for something around 40 to 50 nanograms. Okay, but the main thing is, one thing is, the vitamin D level should not always be interpreted just by itself. I would also consider checking the PTH, the hormone for the parathyroid, and the calcium level as well. Okay, preferably the ionized calcium. So that's the not the total calcium. So the ionized calcium is the calcium that's available on the bloodstream, and that will be used for remodeling the bone. Okay, so the reason for that is that the vitamin D, PTH, and calcium work together. Okay, so if vitamin D is low, but calcium absorption from the gut, in that case, the calcium absorption will decrease. The body, it may compensate by increasing the parathyroid. Okay, so you dropped the vitamin D, you're not absorbing the calcium, and so, but the calcium is one of the most important ions that our body it needs for functioning the muscles as well, for you to walk around, for you to think, for the connections of the neurons, all of that. So your body will try to compensate that, and the first is to increase the levels of the PTH. So if you have a high level of PTH, it means that your patient is already compensate for that. Okay, so we have two two aspects here, two scenarios here. One is a patient with low vitamin D and low PTH and low calcium. Okay, that patient, he has a deficiency, but he didn't adapt to that. He didn't did the turnover yet. So for that patient, I would supplement the vitamin D, correct the levels, and then you follow. However, if you have a patient uh, with low vitamin D and a high level of PTH, it means that the body is already compensating, and and it's not metabolically ideal as well for bone healing, you know. Uh, and that can also mean that the patient could have already a primarily hyperthyroid as well. Okay, so the level, you can be the one doing the reading of a disease of a patient necessarily. And yeah, so how I would level the levels of the vitamin D. So basically, again, and more drastically for patients, and this is actually described for the health association, for improving a patient from 10 nanograms. A common medical correction would be vitamin D3 at 50,000 international units once weekly for about 8 weeks. So that means 6,000 units daily, okay, for 8 weeks. And after 8 weeks, you keep the level at 1,500 to 2,000. Okay, so you maintain the levels of the patient throughout the healing, and then you check again, and you're gonna possibly have the levels at 30. That's is to get to a 30 level. Okay. However, it depends necessarily on at what level the patient is. So if the patient is 20 nanograms, uh, you may need less time, to achieve the same. So instead of 8 weeks, that would mean for 2 months, you can do the blood test within a month and a half, and see how close you are there. Also, because if you, instead of 30, but you achieved at 25, that's already is not as the same as low as the 10. I would be okay to proceed with the procedure. Okay. So all of this is the talking about all of this, the timing, it's super important. Okay, because necessarily we could see that it takes at least a couple of months for a patient to come from a really low level to a proper one. So it doesn't, let's say, for a patient that you check the blood level, it doesn't mean that you just give a tablet of vitamin D for the patient prior to the surgery and you're going to be fine. The levels itself, the blood levels, they should be fixed, and that takes some time. It can delay, let's say, the procedure, and that's a problem, mainly because the patient comes to us right before a wedding or a super party that he has to have a short timetable, but like, you need to be the one standing for your procedure and basically informing the patient that, okay, I can do another solution for you. You can go to the wedding with something like a temporary or something. We can do something for you, but it's better for this, so you can have a long-term fixing for your case. Otherwise, that's it. They just keep saying to you, oh, but I see on ChatGPT that another dentist, and then that's going to be terrible. So another high high risk condition is the use of steroids, as I mentioned there. Okay. Uh, that must be clarified because patients often use the word steroid for very different substance. Okay. Corticosteroid is one thing, and anabolic steroid that we see for bodybuilding, it's another. Okay. And that wouldn't interfere. There is no study for anabolic steroids interfering with implants. But corticosteroids such as prednisone, and dexamethasone are used for asthma quite commonly, and autoimmune diseases. So any patient with arthritis, inflammatory disorders, transplant protocols, psoriasis, all of that, they can be in use, and continuous use of corticoids, and that patient necessarily it's of concern. Okay. And the concern here is with chronic systemic use, not a single dose. As I said, it's not because the patient had another surgery and took dexamethasone for a week that he's going to be compromised. This is for years and years. Okay. And this one class of medication, as I said, that can cause osteoporosis in long term. And the concern is also with delayed wound healing, okay, increased infection risk, and altered collagen metabolism. So we could see that the patient has severe changes in bone turnover. More, I would say, than for a patient for an implant. It would be more drastic for a patient for a graft, because we are talking necessarily about a larger bone turnover necessary here. Okay. Uh, One medication that's not listed here, I believe, but just to be sure, I'm gonna talk about this now. I'm not sure if I place it later. For bodybuilders, the anabolic corticosteroid, anabolic steroid is not a problem. However, they quite often use the blockers for estrogen, like anastrozole. Okay, and that can cause in the long term problems with osteoporosis. It's just like if blocking the estrogen, they become an old lady. It's the double side of the sport. So continuing here, chemotherapy and radiotherapy requires medical coordination. Okay, that's another thing. In patients currently receiving chemotherapy, the main concerns are neutropenia, infection risk, okay, the keep counts of the number of platelets, and the mucosal healing. Okay, the mucosal healing, that's the main thing. It's not even much about the bone. And all of that is due about the timing. Okay, so implant surgery should not be planned without communication with the oncology team. That's the main thing. Okay, you are not dealing with the patient by itself. And honestly, in these cases, the lack of teeth is not the priority here. It's just to keep the patient alive at first. Uh, but if chemotherapy is about to happen soon, one thing is I would not start the implant surgery. Okay, if the implant has been already there, placed, and the chemotherapy will start, then what you need to do is to inform the oncology team, ideally. Ideally, soft tissue closure should be stable before the chemotherapy begins. So that may delay if you had placed. It happened actually to myself as well, but not for an implant. Thank God it was just for extraction. I did the extraction of a wisdom, and right after the patient found out that he had melanoma. I don't know, don't remember the place, but it was a melanoma, and he would start the chemotherapy, but they delayed a little bit the treatment because of the healing of the soft tissue still, and mainly because in this case it would not be as fast as healing the soft tissue on an implant, the wisdom. Sometimes it takes more time for all of that to fill up and become round and sound as nothing happened before. But like, that's it. All the you need is for the oncology team to be informed, and they will deal necessarily with the procedures there. Just a second. I'm just trying to find my nose drops. Oi, você consegue trazer o meu remédio de nariz aqui, por favor? My nose is blocking. I'm kind of addicted to that. Yeah, that's terrible. Uh, okay. So a minimum healing window would be around 7 to 10 days. Okay, that's what they are going to be aiming for. 10 days at least for the end of the tissue healing. Okay, but and talking about implants, it does not mean that also integration is complete, of course, but it would be something to give you more safety. And of course, during chemotherapy, you do only urgent dental care, okay, and always coordinated with oncology, because when you're doing the chemotherapy, you have windows for the treatment, so you are good to go. When you're talking about chemotherapy, you're good to go for a procedure right after the end of one chemo, and then you're gonna have at least a couple of months for doing something for emergency, or for the urgent for the patient. Basically, when we are kind of changing the turns here, the patient went for the chemo first, and now is being referred to you to remove every possible spots of infection, because that's gonna be necessary for the future. You don't know, the patient doesn't know if it's gonna need any radiotherapy as well. That can be possible, and for the radiotherapy, that's even more critical for having infection spots. that can easily lead to osteonecrosis, because everything that could lead or could demand more of the bone remodeling for radiotherapy can become osteonecrosis. And the infection there is one thing, because let's say the cyst with the pus with the bacteria is there. It is a constant damage to the bone, and the bone is fighting back. So that even if the patient doesn't feel anything, that can lead to problems. And in that window, necessarily you can. Obrigado, filha. In that window, you can do the urgent treatment, and then give back, return the patient to oncology. Okay. And after that, let's say after the chemotherapy, the patient is fully released from chemo. Now he's returning to you to then see what to do. The main thing is there is no fixed number of weeks or months, okay, before you think about placing an implant. There's nothing stable in there. So the main thing is wait until the patient is medically stable, the mucosa itself has recovered from from the treatment, from anything from the chemo. The infection risk mainly is controlled, and that is going to be informed by the oncology team. Okay, controlling the cell count mainly, as well the neutrophils and the platelets of the patient. So when the patient is stable, the oncology team itself, they should be the one responsible for saying that the patient is okay for you to do whatever surgery you have to do now. Okay. And other aspect would be radiotherapy. This is more site and dose specific. Okay. If the jaws are not included in the radiation field, the risks are lower. Okay, so the risk profile is different for those patients. Or if the maxilla or the mandible receive radiotherapy, the risk would necessarily depend on the dose, but it would be increased quite much. Okay, field site, time since treatment. Okay, the when did the treatment happen? uh, you're gonna check about the vascularity of the area. Another good sign is the xerostomia of the patient. If the patient's salivating well or not, that means that the area has been quite affected by the radiotherapy, and you're possibly gonna have problems with the bone as well. And also, quite important for that patient is the oral hygiene, because as I said, it's a patient that is gonna have trouble with the bone turnover, and the bacteria. It's gonna be something really impactant for the healing of the implant necessarily. It's a patient more, let's say, prone for infections. So the healing is not gonna be that good, that right. So necessarily, I would consider implants in 2 stages: no immediate loading, no exposure of any part of the implant to the oral environment, trying to protect it as much as possible. uh, but before head and neck radiotherapy, the priority is dental stabilization. So just like the thinking for chemotherapy, the important here is to stabilize the patient, so the patient doesn't have any focus of infection, any potential focus of infection. I've had to pull out teeth of patients that he only had a really deep feeling, but no signs of apical cyst or apical resorption there. However, I did the cold test on every tooth just to be sure. and that tooth wasn't responding that much. So it means that potentially in the future, that tooth would be developing. So that's quite important. The code test for checking what tooth is vital or not, that should be one thing to do for those patients. And then, unfortunately, you remove that tooth, you remove whatever tooth is non-vital, and then you deal with that later. Uh, in general, okay, the implant or any procedure, but we are talking about implants here, they should not be done earlier than 6 to 12 months on the patient, okay? But that will depend still on the site that the radiotherapy was done, and the intensity, the amount of radiation that the implant suffered. Okay, in general, for sites that received more than 50 to 60 doses, or when the graft itself would be required, I would be much more cautious with that. Okay, uh, checking first if there's no other reactions on the bone. Sometimes you can see some it's just like some cells into the bone, like meaning that the patient is showing some osteonecrosis already. So just check for all the possible things. However, if the patient did the radiotherapy in any other part of the body, in general, they protect all the rest from the action of the radiation. So in those cases, I would still wait for the 6 months time, so the body can dissipate part of the radiation itself, but it would be safer. Now, starting with medications. This is, I believe, more complex than anything else. The medication history should be not treated as a simple checklist, not at all. All of that, they have interactions in between the medication. It depends on the type of medication, depends on how long the medication has been taken. So there's lots of things. So it must be interpreted according to the mechanism, dose, duration, and route of the administration. It's not the same when the patient has a biphosphonate on tablets and IV. The IV is much more potent, has much more, let's say, uh, it's not a level. Yeah, but the levels of the medication on the bloodstream are much higher. So that patient will be much more impacted by the medication than another one that had only on tablets. Okay, so the first group includes medication that may reduce bone density or contribute to osteoporosis, such as prednisolone, prednisone, and one of the classic examples are the corticosteroids, but they are different. No, sorry. Yeah, I would say, yeah, I listed here the anabolic steroids. That's the difference. I was just not sure. Yeah, I'm getting old as well. Like it doesn't lie. The beard. I don't know what I had for breakfast. So, however, some medications used in bodybuilding contexts, as I said, the aromatase inhibitors like anastrozole, it can reduce estrogen, and that can increase the bone loss risk. I had a patient as well that he was taking GH, the growth hormone. It did an impact on reducing the bone, or it actually was the opposite. After taking for some time, he started having a spike on the lingual wall of at the back of the tongue. It's just like an area that had already some torus, but like in an area that is not usual to have a torus, but because of the hormone itself, that grew even further. That can be something interfered by the medication as well. Other drug family associated with reduced bone minerals density included androgen deprivation, and I think that would be trending for now. So, are medications for suppression of the androgen hormones. Okay, so now that the transitioning from one gender to other are becoming more common as well, this I believe that will be of more concern necessarily. Okay, that can interfere quite drastically with the density of the bones as well. Excessive thyroid hormones, anticonvulsivants, antipsychotics, uh, antiretroviral drugs. So patients with HIV, they could have problems as well with the osseointegration. Uh, Calcineurin inhibitors used in transplant or autoimmune patients. Lithium, and one here I don't think I've listed. Oh no, yeah, it's right after. And one that is I don't know, but at least I neglected this for quite some time, is the proton pump inhibitors. That's the omeprazole necessarily. There are some patients that they have heartburning, they have chronic reflux, and it's kind of a drug that you take by the counter, so you don't need prescription for that. So it's a drug that can easily be abused, and the patient doesn't give the proper importance to the to that necessarily. So this is something that possibly you're gonna ask the patient what drugs he usually takes, and he's gonna left behind. Okay, so I would specifically ask for those, because if the patient takes that for a long time, that can be also reducing the density of the bones. Okay, and other drugs for attention, for controlling the attention, like sertraline, fluoxetine, they also interfere with this systemic bone turnover of the bone. So all of that, uh, however, all of these associations, they not prove causation. So again, it's not 100% because they take the medication, a part of the biphosphonates necessarily, but this that I listed is not because they take the medication that you're gonna have a failure on your implants. Okay, but it's something that it has higher potential. Uh, because of that, I would, instead of risking, let's say, a long treatment or a more complex treatment, I would try to reduce it. Okay. Now, no non-steroids anti-inflammatories as well. If the patient takes that chronically, any ibuprofen, that can lead to a density problem. Okay, a long life. And now the anticoagulants as well. So patients on the warfarin and other medications that interfere with the coagulation, that can cause problems with the bone density. Uh, but like for those ones, more than anything, the clinical focus would be with the local hemostasis during the surgery. Okay, more important even than the integration itself is how you control the lack of medication, because you have to stop the medication for some time, do the surgery, go back, and there's a kind of a protocol for you to properly uh, follow, for those. Uh, okay, so going now specifically for the biphosphonates and anti-resorptives medication. So the main concern here is related to osteonecrosis, of course. Biphosphonate and denosumab, they both reduce the osteoclasts, mediate bone resorption, but they act differently. Okay, so it's not the same the patient taking biphosphonate and the patient that takes the noxumab, that's the Prolia. Okay, the biphosphonate, it binds to hydroxyapatite on the bone. So the biphosphonate itself, even if the patient stops the medication, that medication will be still binded to the bone. So it's a patient that will always offer more risk for osteonecrosis. Okay, but again, the patient that takes it as a tablet, depending on the dose, it would be of less risk than a patient with the IV medication. The IV medication, it's something necessarily that I would not touch. It's something that will be forever there. Now the Prolia itself, it does not bind to the bone. The Prolia acts differently. It kind of stops the rank L, so it's a different process necessarily. And for that medication necessarily, it would be, if the patient has stopped, it would be safer for you to take to follow with the procedure. However, one important thing here is to still consult the doctor of the patient, because that patient is taking the medication for some reason. So the patient can still, let's say, be a risk of fractures in other areas of the body. If you stop the medication and the patient has, let's say, a fracture on the leg or something like that, that's going to be on you. If you didn't consult the doctor, the GP, it's going to be a problem that you brought to yourself. So for all those patients on continuous medication for a systemic condition, I always consult the GP, so at least you could share the responsibility there. Because in that case, it's not you saying no necessarily to the patient, it's the other doctor saying no. That in general, the patient understands better, when it comes from something that he has already. Okay. And now we kind of listed all the systemic conditions, all the possible conditions that the patient could have. And if you got here checking all the boxes during the anamnesis and everything is negative, we may say that the patient is systemically healthy. So we may say that it's safe for you to do the implant and everything can go right. But like for the implant to go right, now we have still a long way to plan. Okay. Because it does not automatically mean that this is a low risk implant case. A health patient can still have a high risk implant site. Now we are talking more about local aspects of the surgery. And this is where move from systemic diagnosis to local and anatomical diagnosis is important. Okay, if we if we talk about aesthetic zone, it goes even further. Okay, the first structure I want to understand is the buccal plate, if it's present or not, if it's thick enough, if after doing the extraction that buccal plate will remain there. And also a useful way to think about extraction sockets is using the Alien classification that it divides in type 1, type 2, and type 3 sockets, okay, where The type 1, the facial soft tissue and buccal plates are fully preserved. The type 2, the soft tissue is there, still present, but the part of the buccal plate is already missing, so it has some bone absorption already. You just don't have the static problem of the gum receding at the beginning. And the type 3, the where everything is gone and the static is already compromised. Actually, I believe that the type 3, uh, the type 1 is always better, but in between type 2 and type 3, the type 3 would be better because the expectations are already low, you know. So for you to do something good from zero, it's better than the oh, I never had that before. No, that's a nightmare. So this is clinically important because a thin or missing buccal plate changes the risk completely. Okay, if the buccal wall is very thin, especially around 1 millimeter or less, the extraction itself, all of that, it is more prone for remodeling the bone, and then you get the recession. The contour of the gum collapses, and then is an aesthetic nightmare necessarily. Uh, and if we place the implant too buccally or create excessive compression against a thin buccal plate, we may accelerate recession on marginal bone. Okay. The second point here is that the bone quality. The patient may be healthy, but the site may have soft trabecular bone and reduced cortical. So all of that limits the apical anchorage. You know, so it's just the apical holding the implants. Sometimes it's not enough to sustain the lack of micromobility. Okay, in these cases, torque alone should not give us false confidence. That's the main thing. Okay, we need to understand where the stability is coming from. Okay, if the implant is supported by the surrounding walls, at least one wall just for the support of the implant, I would leave more time for that implant to heal, so all the rest could contact could come to a bone to implant contact properly. The third aspect here is the soft tissue phenotype. Okay, for patients with more uh, inserted gingiva, that's much better. A thicker gingiva is also better. We know that's not actually the major part of the patients. In general, if I'm talking about a single implant, I always try, even if the patient doesn't need that much, but I always try to do along at least a row flap, you know, or something that I could increase the thickness of the soft tissue necessarily. And the row flap is a really easy technique that you can do at the reopening time. We have also some prosthetic parts, some abutments in root that we can have use of that, so we can increase the amount of soft tissue, like the narrow healer. Okay, that will increase during the healer the amount of soft tissue around the crestal part of the implant. And at the time that you do the impression, at the time that you place the crown, you do incision on the gum to relieve the stress, and the crown will be inserted pushing the gum around, so you create more volume around the crown. That's important for the long term as well of the preservation of the implant. So in that way, we need to assess the mucosa, if it's keratinized or not, the patient comfort during brushing, play control, mucosal stability, inflammation control, all of that. In general, less than 2 millimeters of keratinized mucosa around the implants is commonly considered inadequate. You know, it's not as favorable. Uh, More than that would be desirable necessarily. One other thing that you can do, as we can see here on the slide, is replanning the how deep we are placing the implant. Okay, so we can have at least considering the soft tissue 4 millimeters from the top to the collar of the implant, instead of just placing the implant at bone level and thinking that this is safe. But the patient has a gingiva there that is 2 millimeters. Your implant is going to be just 2 millimeters away from the crown. That can lead to a lower, a smaller amount of soft tissue around the implant and problems in the future. You know, so plan the position of the implant regarding the mucosa, not regarding the bone. Sometimes instead of placing a longer implant like this, it would be better to place a shorter, insert more into the bone, be safe there, and then you're gonna have much more tissue, not only bone tissue, but the soft tissue preserving at the top. Okay. And again, graft in these cases, the static cases mainly, it can preserve the contour, maintain space, and guide bone regeneration, but it does not behave like mature native bone from day zero. Okay, it does not automatically increase stability. It takes time for your implant to gain stability from the bone graft. And one thing that's important here to think as well is that the drop of the primal stability is not consistent. It's not because the implant has good primal stability that you can think that the primal stability will drop according to the second one, and at the fourth week I'm gonna have let's say a curve that will be growing. No, depending on how much the bone graft is around the implant, the prime stability coming from the native bone, it can be inconsistent. You can be a larger remodeling there, and if your implant is not preserved from occlusal trauma from other aspects, it can create a micro motion on the implant that will damage necessarily the stability of the implant, even if it was at first 45 newtons, you know. But like the 45 newtons, when you have an implant like this, you know, like this size, and the implant is fully surrounded, is one thing. 45 newtons when the implant is only like this, even if it's supported, is another thing. Okay. And one thing now, when we consider the aesthetic zone that is trending, it can be a little bit controversial, but it's changing necessarily, is not as much. We are coming with more articles showing that, let's say, partial extraction, that tooth preservation, it's being quite effective for these cases, is techniques that you preserve at least part of the tooth. Uh, One of that would be socket shield, where you partially preserve the buccal aspect of the roots there, and you leave that will heal, that will integrate, and will preserve the contour of the buccal plate. And more importantly, if you are doing full arch for FP1, I would consider for the whole, at least necessarily for the whole sites, that you don't have to place an implant to do, or leave the root there, you know, or do a partial extraction, because that will preserve not only the buccal plate, but the totally forgot the word, but the bone in between the roots that will keep and maintain the papilla. Okay, so with that, it's easier for you to preserve the papilla, even in between two edentulous area. If you have that part of the tooth there still, the papilla will remain there for longer. And here we have an article that I published with Dr. Mahab, really good friend, where we kept the only the crest, the not the apical, by the coronal part of the root, in a way to use that as immediate, as a customized
So to
abutment.
speak.
Okay, the difference with that from a customized abutment necessarily is uh, the ligaments around the tooth, they could bond again to the tissue. Okay, so this I didn't place anything to comparison, but this would connect with the tissue again, and that would inform to the bone that nothing happened. So the it's not like if you removed everything and still placed customized abutment, but like for the body, okay, something happened here, and I will remodel this buccal plate. So this would preserve better the buccal plates, as we can see here. The level, actually, no, it's okay. So here we have the bone, a totally unfavorable buccal plate here. That's the top tooth that the patient had backwards, and we can compare to the later situation here. We can see I grafted this area, but the buccal plate around the graft is totally preserved at the same level of the that it was before. Okay, and how did I do it? I used a ZBL abutment. Is the most versatile thing I ever see in my life, that can be used for everything, like for customized abutments, for scanning, for impression, for the tempers after. You can use this part for everything, and it comes for free along with the implant. That's the crazy thing. Like, my boss is crazy, and he's doing this kind of things. And here we can see the root part, the root ring in position, and the the aspect of the socket right after. Okay, actually right after the healing process. Okay, at the time of the impression. And now, as I said, the CBCT, that's not only important nowadays, okay, but that gold standard. Uh, if you have any litigation with the patient, and you did only an OPG, only a regular X-ray, any other X-ray, uh, you're gonna have trouble explaining yourself legally of why you didn't do a CBCT. Okay, why is that? Because the implant is not something that is in just one dimension, is in just one aspect. The bone has a three-dimensional aspect, and you should follow that. So it's just not direction, it's multiple directions there that you need to follow with the implant. So that's the main thing. So you can necessarily assess where's the buccal plate, where you're gonna place your implant, how you're gonna deal with all of that, how deep you're gonna go with your implant. If you're gonna go deeper, as I said, to preserve the amount of tissue at the top. And according even to Professor Zucchelli, is even easier for you to rehabilitate an implant that is deeper rather than an implant that's shallower. Okay, so if you need to do any mistakes of position, put it deeper, because with that in that way the abutment that you can build can be narrower, that will give more room for tissue to be around, and you can, with that, you can grow more tissue, even if it's with a surgery later. Okay, the only thing, the thing with the CBCT is it will give, let's say, a better idea on the density of the bone as well. You're gonna analyze, you're gonna assess that locally on the bone on the patient. However, it does not work as the same as the exam for the densitometry. Okay, so not always you can look for the gray zones there on the CBCT and expect that to be or the term if that is more dense or less dense. Okay, it can give you, let's say, an overall idea. It can make you more prepared for that, but still your clinical assessment at the moment of the surgery, that is gonna be key. So my advice is to go with the pilot, feel the bone, how is the bone there with the pilot, and then you change your drill protocol accordingly. Okay, so you can achieve a proper stability. And here, let me see, just, yes, it goes one by one. We can see a case of a patient that came to my office there with a play. Actually, she was asking just to change the crown. That case is later. I'm gonna show you from the beginning. The crown was terrible, but at the end, I noticed that the implant had a small mobility as well. And why is that? We can see here that is not lack of is not because of any systemic problem of the patient, is not problem of anything else rather than the position of the implant. Simply the implant has been placed just too buccally, and it wasn't deep enough as well. We can see the later pictures that the, let's say, the metal was already showing through the gum. We could see a grayish part under the gum there. So basically, that's it. Like, if you do not have a three-dimensional idea of what to do, you're gonna be in trouble. Okay, and it took me a while to fix that problem as well. So for that patient, I followed with the extraction, with the deplantation of the implant. I managed to place this other implant as a root 3.0 immediately, and I did a bone graft at the buccal just to preserve that area, to gain more volume as well for the later rehabilitation. Okay, everything else fine. This one is the final X-ray, so it's later all the healing process. Okay, but these implants, I chose to leave the implant fully covered. So I didn't do any healer. I didn't do any temporary as well. The patient was using a removable temporary that I did not as a denture, not as something that could be supported by the grafted area or the gum, but I used kind of a clear tray like those for Invisalign treatments with the fake tooth there in position. Okay. So when we talk about immediate loading, one thing is that it is not only about torque, as we have been discussed all the presentation today. So torque tells us about mechanical engagement at the moment of the placement, but it does not tell us whether the implant will be biologically protected during the healing. So torque is of course important. Ultimately you're gonna, let's say, aiming for achieve at least 30 newtons to 45 newtons. Okay, However, if you have implants with much less than that, I've placed implants with 10 newtons and it was successful afterwards. The most important is that the implant does not have any micromotion. So this one for the 10 newtons, uh, I simply covered the implant again. I didn't leave anything of the implant unsupported, and it wasn't an immediate one. It was an area that it was on a healed site. So that made possible for the implant to be, let's say, without torque, but with not shaking because it was inserted necessarily on the spots drilled. Okay. So we need enough, let's say, primal stability to reduce the risk of micromotion. That's it. So if you have a hole specifically at the size, a socket that's specifically at the size of the implant, and that it would be enough to prevent the implant from shaking, that's it. That's fine. But the because the main objective here is not to achieve highest torque. Highest torque, it can be damaging the bone structure, mainly for patients systemically compromised. That can be a really good problem. Uh, so the choke slow mechanical engagement, yeah. One thing really important for the immediate loading, as I discussed at the very beginning, is the design of the implant. Okay, so that's necessarily explained to us why we came from the cylindrical implants of Brandmark, fully machined with no surface treatment, to what we have today. And for roots, we have the implant with a body taper of 14 degrees. Okay, that in general is compatible with a more aggressive implant, kind of implant. Along the insertion, it creates more compression according to the implant insertion. You're gonna have single body implants from roots that in general they are six degrees, so that is more gentle for with the bone. I would say that it's more advisable that for narrow ridges where you have more, let's say, risk of fracturing the ridge itself, you don't have much bone available, so that would create an insertion with less tension, okay, with less compression around. And the progression, the progressive changing on the threads, as I said, from V shape, that where you need more, let's say, for that to be more aggressive, for that to lead the entrance of the implant, so that that's what will create more primal stability necessarily into more scratch shape. So we at the crestal part, you could be more gentle with that bone, so you could preserve that bone better. You have also the double thread helix on the implant. That is one thing that's quite important for the brain mark. The first implants, they had only one helix of of the thread, and that is just like literally because he was copying. He didn't have any idea on how he would respond, so he was copying basically the screw that we have on the engineering. So I place a screw, so let's place a screw, that's it. But like that takes too long for the implant to be inserted. Like you need to spin and spin and spin for the implant to go in. That's not only it's problematic for the stability itself, because you can start damaging the bone around according the insertion, but it increases the temperature along the insertion as well, so you can have some biological changes within. When you change that for a double helix, you can increase the speed of the insertion without creating that much temperature stability, temperature changes. Okay, so the root implant is designed for every turn to be inserted. One is 1.5 millimeters. Yes, exactly. So every turn that you do, you insert 1.5 millimeters of the implant. That's good as well. Just not only because of the biological parts, but like for you to be more predictable, because when we say for every turn, and we are doing with the wrench manually the turns on the implant, we don't do one turn because the head of the patient is on the way. So in general, you do a quarter of turns, but still with that, beforehand how much you're going to be inserting that. So if you look, let's say, okay, I need instead of 1.5, I need 1 millimeter. Instead of one full turn, I do just three quarters, and I'm there. My and for microgeometry as well, lots have changed. Uh, from Brandemark, we had only machined implants, so it's straight from the milling machine, without anything else. But after, it was noticed that implants that would have more problems on the surface, they would integrate better. So problems like making the surface more rough. So with that, we came with the concept that rougher surfaces would be better for the integration. And now there are lots of ways to achieve, to increase that roughness, and that not only increase the area of contact, but increase the let's say the attachment of the early cells of the macrophages for the implant, and that will lead to better integration of the osteoblasts, of the fibrinogen and all the healing process, making the bone going towards the implant and creating that bone to implant contact. Okay. Now, when we speak about late failure, it is different necessarily from early failure, because at some point the implant had already achieved osseointegration. So now the question is not why did the implant fail to integrate, and is more like what changed around an implant that was previously stable, that was previously good. Okay. So from the biological point of view, the plaque-driven inflammation is the main concern, of course. If peri-implant mucositis is not diagnosed and controlled in time, it can progress to periimplantitis and progressive bone loss. So it's important to inform the patient that he must come back to you for reviews. If not to you, with any other dentist, but it would be a good way for you on the consent form to calling that patient at least for a review with the hygienist, if not with you, but you keep that agenda, you keep that patient within you, and also makes the patient more compliant with his own hygiene, because he can have a close follow-up, a close idea on how he's actually keeping the implant necessarily. Okay, a way to make more money as well. But this biological vulnerability, it's always good. We are we are in a capitalist world, it's all about money. And this biological vulnerability is not for every implant, for every patient, and every implant as well. The systemic condition can change how the patient responds to plaque. Like a patient with diabetes, or HIV, the immune response of that patient, it's lower necessary is compromised. So that patient, instead of every 6 months, I would recall that patient every 3 months at least for a cleaning, okay, for a review. And that the patient has to be really aware of his share or the responsibility as well, so he can keep with that. Uh, Diabetes. The risk of that is the peritonitis, as I said, marginal bone loss. It has the immune response impaired, and of course, because of that, the long-term implant loss becomes higher. It doesn't mean that we should not again do an implant for a diabetic patient. Okay, a patient with the diabetics under control is a really good patient. It's just like it has the same risk of losing an implant that any other health patient. It doesn't increase at all. The problem is when the glycemic control of the patient goes out of hand. Okay, and to help the patient as well, it's just like that protocol of keeping the hygiene, keeping the other features under control. Osteoporosis itself is slightly different. Okay, osteoporosis alone does not appear to increase implant failure in the same way. Okay, the literature suggests that implant survival is can be compared necessarily to regular patients. Uh, it would matter more because it may reflect altered bone metabolism. Okay, so reduced bone density and possible, and it would be more related to the placing, the moment of the placement, and possible medical related risk. Okay. However, an implant, let's say, placed on a patient that is having a problem now with osteoporosis, we could have an implant that's fully integrated, fully stable, and now the bone around that implant is becoming less dense. So we can agree that for that patient, the occlusion itself, how that implant will perform under stress will change. Okay, so if we are talking about a patient that is a bruxist that grinds too much, that implant with time will suffer, and it can come off, fully. Crown and implant, everything just comes off. So I also advise for, honestly, not only those patients, but like in general, I like for doing a night guard for my patients. Okay, if I have any signs of bruxism beforehand, there's some erosion on the occlusal, a little bit more severe, just go with a night guard. Okay, it will give you peace of mind. Again, it's one more thing for the patient to be more compliant. The patient, it kind of likes the attention. Okay, I have to go back. Even more if your reception has a good cough machine, the patient will be coming back. Be sure of that. Okay. So necessarily these loading conditions, it will interfere with time. Okay. uh so late failure is rarely, let's say, explained by one isolated cause. That's the main thing. Very often it is a combination. A patient with a systemic susceptibility, history of periodontitis, prosthesis that is difficult to clean, so the contour of your crown needs to be perfect, let's say, or at least closest to that necessarily. Residual cement, that's quite important. Okay. Over contouring of the crown, all of that can drastically interfere with the longevity of the implant. So going back to that case, I showed you guys about the implant that was placed too bulkily. This is the same patient. So on the first image here, we can see the 21 with a huge overlap, a huge area. I like the dentist did no effort at all, to to do a tooth accordingly. No, like I'll just put something here at the same size that it should be, and that's it. And we can see here a grayish part under the gum. That's the implant that was showing under the gum already. So this not only, we cannot even blame, let's say, the fully the position of the implant, because that over contour of the crown necessarily it could have driven the implant into an infection, a periimplantitis there, and then the lack of wall, the lack of bone, because it didn't have much protection, it could be more easily affected. Perhaps I could say that if it wasn't for the overhanging part here, possibly the implant could stay there for longer, not with a good aesthetic, yes, but like it would be integrated for more time. So this case, what I did, as I said, I removed the implant. I did the immediate implants there with the bone graft, so we can see here that we have already a better contour, is going closer to what is the surrounding teeth there. But at the end of the healing, I could see that it was close, much better, but still not there. It was missing 1.5 millimeters, possibly 2. So now, at the moment of the reopening, what I did was I opened kind of a nest flap from here, going back to this area and back here, okay? And I deepitalize the palatal part, going to the center of what would be the incision, okay? So this part was deepitalized, and I rolled this deepitalized part into this area, like this. Okay, just like folding a napkin, folding a shirt. Okay, and that is the temporary crown. So what we can expect now is, along with that technique, the temporary crown will shape the gum around the implant. And what we have afterwards, that's the final one, is a gum that's fully healed. Now we have a contour that is even greater than it was before. And compared to the crown that was previously, and sorry, I tried my best to put this image on an horizontal position, but I'm not a tech guy, so it still is up straight. But we can see now the contour of the crown, without any over contour, coming fully from the inside of the gum. Now, like necessarily the aspect of a proper tooth. Okay. One other situation, actually, this was just to show here. This was from another article that we published as well. You can all see that at the Journal of Dental Health or Research. Oh, from this year. So another case as well. This was quite good. And we are just coming to the end for all of you that are hungry. So here we have immediate implants placed on the area of a molar. Okay, for this case, I didn't use any partial extraction. It was only the graft around, And for preserving the graft and preserving the bone, I've used a customized abutment. Okay. You can see a small white tip here. That's the gelatin is not a collagen sponge, but is a hemostatic sponge I placed under the crown. Okay, so it could be kind of separation from my crown to the graft itself. And at the end, the patient had another implant here that I did as well, like at least 4 or 5 years ago. I didn't do any. It wasn't immediate. I didn't do any preservation or customized abutment, but because of that, we can see the difference in between the crown with the customized abutment, a better preservation of the contour of the soft tissue from the one that didn't receive the customized abutment itself. Okay, and yeah, that's the end of the presentation. I hope I could have cleared
Thank
uh,
you so much,
his
Dr. Bruno.
mind.
It was really, really amazing and informative. I think most of the doctors or the people who are attending the webinar, they have the answers to the complications that they usually encounter in day-to-day practice. Like you covered the systemic health in a very elaborative way, especially about diabetes, smokers, and what can happen and how they can select and choose. So each and every aspect of the webinar was highly informative. Really, thank you so much
Yeah.
about this informative webinar. We have some questions that we would like to take. I know for everyone it's
Now,
quite late, but everyone is still till the end. So I'm quite happy
I have
about
one
this.
here from Sabha. In situations where
Yes.
when 2 or 3 threads of implants are exposed, if I graft and cover by membrane or just graft the threads. Uh, you have some articles that they show that if you only polish the threads, you make that area more polished. Only by that you can have even a vertical growth of the bone. And also the main thing is to remove. It's not much important even to do the graft itself. I would say that possibly that graft would not be perhaps integrated. It would more created a volume under the gum on the soft tissue rather than integration than making the bone to grow. But yes, the main thing is to control the bacteria, and to control the bacteria, just like the bone, the bone itself, like rough surfaces. Unfortunately, bacteria also does. you know. So the area that was in our favor on the integration of the implant now it's on the way with the bacteria. So you just need to make that polished. You do really good decontamination of the area with citric acid and endogain. It's quite good for that necessarily, and you're gonna have already some good results. I would say that I necessarily wouldn't do necessarily graft. I think with that would be already good, already done.
You can
Now,
also perform something called as implantoplasty because this we usually do it. You can make the collar smooth by doing some treatments. This is usually a treatment which is non-aggressive. So you try to make this collar of 2 millimeters or 3 millimeters smoother so that you have tissue integration. Because bone, it's very difficult to grow in such cases. Bone will not grow, unfortunately.
yeah, the concept of that bone implant reduction would be necessarily the same as preconized by Dr. Zucchelli, is to make everything as narrower as
As
possible
possible.
to create space for the soft tissue. And because more than bone, the soft tissue in this case is the most important. Okay, that's one of what's going to preserve the rest of the implant, rest of the integration. The rest of the implant down there is going to protect from the bacteria, from the external environment, and that's going to be better than trying to gain more bone volume. Now, in cases of infection in socket tooth extraction, Yes. What I do, so the in general, you need to check if the infection is still active. Okay, that's the main thing. If the patient has a really active site supporting oozing pus and all stuff, what I do is at least 1 week or two of antibiotics that will control the infection and that will make the site more prone for accepting the graft and the implant. You just need to be 100% sure of your curettage, so you don't leave any fibrotic, any infected tissue behind. After that, you can do the irrigation. I would do the irrigation only with saline. Okay, there are some articles that they say that the chlorhexidine it changes the metabolism of the bone in there, so you can have some surprises. But then yes, just irrigate, rinse with saline, and do your graft, protect your graft, and it should be fine.
So this is a question which was posted in the second channel. It was early implant failure versus late implant failure. Is there a time limit, which may be 3 months to 6 months, or more for early implant failure and late implant failure to define exactly? I think he wants to know exactly what early implant failure means and what late implant failure means, and is there a timeline for it?
Oh yeah, no, that's more for, let's say, articles and books. Early implant failure is for the time that the implant is healing. So it would, I would say, necessarily up to 2 months.
2 months.
So that's the time that the primary stability is still decreasing. You're still counting much on the primary stability, so that would be still early failure. A late failure necessarily is for after the implant is integrated. So the implant is there fully integrated. I've opened already some implants with 2 months from root, with no trouble. Of course, it depends on the primary condition of the patient, the torque that you achieved primarily, the overall condition of the patient. Depending on the case, 2 months, I would say, is still acceptable. I would still be easy, and that's one condition that you need to assess is the occlusal aspects, the biting of the patient. If there is any risk for the patient to be a bruxist or for that tooth to receive too much pressure by any chance, I would delay still a little bit the rehabilitation of that. But like necessarily a late failure would be for after you rehabilitate the implant. So when you are counting that the implant is fully integrated and now he's having trouble.
One more interesting question. Do you have any recommendation sizes for implant height and diameter? I think it's a very tricky question.
Oh yeah, like literally, there's no sizes, let's say, advisable, because all depends on your technique. As I said, I would recommend the size according more to how according to the distance of the soft tissue. How thick is the soft tissue. If the patient has 2 millimeters only, take that in account, because you're gonna need to place your implant deeper to count with that. If the patient has 3 millimeters thick, which is really uncommon already, I think it's more like 15% to 20% of the patients, if not less. Then you're gonna need to deep your implant just 1 millimeter. So if there's anything below that, like the mandibular nerve, then you can go deeper necessarily, but you need to take that in account. Like for other techniques, you necessarily need implants more longer, like a transnasal If you were aiming for something like bicortical, for that technique, you need a longer implant. And diameter, it all depends. For the let's say front ones, I wouldn't pass much the 3.5. I in general I use more 3.0, because as far I stay from the buccal plate, the better. It means that I will have more bone to absorb over time, because that's going to absorb while the patient goes older necessarily. So my implant will be better protected than if I place a 4.2, trying to cover all the size of the sockets that is there, and then I will have an earlier failure for that. But for posterior implants like that one, I did the customizable abutment. I've used a 5.5. So in that one, what I try to do is to gain more because of the immediate extraction. I've tried to use that to increase my contact area. For that surgery, I used a denser burr, so a densification burr to kind of compress the bone at the center to the sides. So I could use that instead of removing, use that as part of the graft. And then I placed the 5.5 using at least two walls of the surgical aspect as for the stability of the implant.
Thank you so much. There is one more thing. There's one participant. She's asking about, do you have a comprehensive consent form? So to take a
I
consent of the patients,
I
because
can have, yeah, I have, but in my clinic I didn't attach to my profile, but I can attach by tomorrow, and it's gonna be at the same. If you get to my Instagram, is here at Dr. Bruno Reis Dublin, then you're gonna have the checklist already, and I can put for tomorrow the consent form.
that would be great. So one more thing, last question. Is it safe to place implants in a 72-year-old hypertensive female on aspirin who also experiences vertigo and dizziness? What are the key considerations?
So vertical and dizziness necessarily would not much be a problem. More for the comfort of the patient. Like uh, I wouldn't just lay the patient too fast or bring her up too fast just for that. But if you go slowly, it wouldn't be much a problem. But like the aspirin itself, it's a really mild blood thinner. So in general, it doesn't interfere much with the blood clot necessarily. Okay. What you can do is to use those hemostatic sponges like the Gelatemp to improve the cloth and try to hold the cloth around your implant, because in that way you're gonna try to bring more blood around the surgery necessarily. But like for the surgical aspect of controlling the bleeding during the procedure, I would say that that's fine.
This is the last question. This is from Maggie. How subcrystal should be the implant? The ideal, unfavorable in terms of millimeters.
Sorry, I
So,
didn't get. Can we repeat that?
how subcrystal should be the implant be?
Oh,
Ideal,
house and parcel. Okay.
yeah, and unfavorable in terms of millimeters. So, what's acceptable, what's not acceptable?
So again, the idea is to calculate that according to the soft tissue. The how subcrestal will depend about the thickness of the tissue. In case you need to do a calculation, you can either use the BCT, because that will give you an overall idea on the thickness of the tissue, not as much, but you can have an idea from there. But like at the moment of the anamnesis of the assessment, you just go with a probe, a periodontal probe. You put some even topical anesthetic, and you insert the probe, and you're gonna see how deep you're going with the probe, how deep, how thick is The soft tissue is the gum on top of the implant. With that, you're going to know necessarily how deep you're going to need to place your implant, how subcrestal is going to be there. And after that, you calculate how long or how short your implant going to be.
It's perfect. So it's technique. This technique is according to the biologic with which Dr. Bruno showed us in his picture. In the presentation, it was 4 millimeters. So the ideal way is to achieve this 4 millimeter vertical height for the tissues, and accordingly you need to place an implant. So if you have 2 millimeter of tissue, you can place the implant subcrestally by 2 millimeter to achieve this 4 millimeter vertical distance. So I think it was a very good, it was not a webinar, probably it became a masterclass. So so we did an online masterclass from Dr. Bruno. It was really interesting, and most of the aspects that you talk about are left untouched by majority of the speakers. They want to talk more about this advance, but the planning, the systemic health, and taking into consideration each and every aspect of the planning part, it's utmost important for the long-term success. And thank you, Dr. Bruno, for your precious time. It was a long time from you, and you took a lot of effort in making this such a beautiful presentation. So like, we really appreciate your time. And also one more thing, for all the participants, if someone is looking for having a fellowship in Royal College of Surgeons Ireland, you can contact me or you can contact Bruno. We will guide you through how to get this fellowship in Royal College of Surgeons. And it's actually a very good fellowship that can be offered, because Dr. Bruno is a professor. He is an assistant professor in Royal College of Surgeons. We can guide you step by step how to get the fellowship. So thank you so much again. Thank you for the patience. Really, thank you, Dr. Bruno. It was really, really appreciative of the time that you invested with us and the participants.
No, I thank you all. Thank you for our time. And any questions, you can drop a message on the Instagram as well. No problem. I will be
Okay.
available there. Okay.
Thank you so much. Have a good day, everyone. Take care. Bye-bye.